We're going to go ahead and shift, and we're going to go with Professor Gilbar Sela. Please.
Hello to everybody. It's a little bit different direction after so many business talks, just a little bit of science, and trying to see in cancer patients what are the new challenges for most of the science and the clinical oncologists ahead. We are all familiar with the indications that are usually used for cancer patients. It's chemotherapy, induced nausea and vomiting, cancer pain, anorexia, cachexia, insomnia, depression and anxiety. All those indications, there are gaps, of course, that we know between the familiar studies that done many years ago, most of them, mostly with synthetic drugs, and the new studies that are basically more cancer reporting, patients reporting outcome than really clinical studies. But those studies are much more positive than the studies before, and that's why the use is so large in cancer patients. But still there are many open questions that we need to deal with it, because the cannabinoid system is very complicated, and we really miss a lot of knowledge. We are dealing with three different aspects when we are trying to push ahead some indication in oncology. We have the different substance in the cannabis plant, and it's not only the phytocannabinoids, it's the terpenoids and the flavonoids and how they are working together. And when we are producing products for clinical use, can we just use it as it is in the planet, or artificially we can raise up some of the cannabinoids or some of the terpenoids and maybe get a better product than we have just by using the medical plant? And what happened to the endogenous cannabinoid system when we are using cannabis? What happens there? How the system works? Is it work pro-cancer or anti-cancer? We are not sure. What happened? It's shut down or it's raising up? It's really open questions that are important when we are dealing with cancer. And of course, we have all the synthetic cannabinoids, the new drugs that are putting ahead. Most of them are still in a basic research, not a lot of clinical research, not a lot of clinical data. Do we improve what we have, or is it just some kind of short indication, nothing is going ahead? So it's a lot to deal with research in cannabis and cancer. We have some very interesting preclinical data because cannabis influence on oncogenic pathways. There are several oncogenic pathways, as you can see, that are very important in the cancer research. Many target therapies are developed or exist in the market to those pathways. Cannabis can block partially those pathways. Is it work good enough to be a clinical anti-cancer drug, or it's just something anecdotal for the research that you are doing in the laboratory? The same way is for selected key molecules like ROS1, EGFR, that are mainly in lung cancer, are really target therapies. And we are looking for those mutations in those specific molecules to target them with very specific therapies. So is cannabis really help to do a better blockade for those patients, or it's compete with the target therapies? We really don't know, and we need to check it when we are treating lung cancer patients. It's not just giving the cannabis, for example, maybe to patients with EGFR mutations. Is it really helpful for them, or is it done the opposite way? When we are coming to clinical trials, we don't know. We have very, very small studies that were done with anecdotal phase 1 study that was done many years ago with intracranial THC, and the phase 2 that it's very interesting with combined temozolomide and Sativex in glioblastoma patients, but it reported very good result in the ASCO, in the American Society of Clinical Oncology, 2 years ago in a small abstract. It was very interesting, but 2 years had passed and nothing new came. So it's really questionable what happened to this study. And we don't have other clinical studies. So is cannabis really a medication for cancer? We are now with BOL Pharmacy here in Israel, and in my center and in other center in Israel are starting, and probably will start in 3 months, a new study that try to test what we call the Rick-Simpson oil formulations, different formulations, to see if it can be a drug to cannabis. Mainly it's a phase 1 study, so it's a toxicity study, but we probably, hopefully, will get some hints about its clinical use. And I think it will bring forward this indication for cannabis for cancer patients for their illness, not just as a symptomatic relief. But we have all the other drugs in oncology. This is a retrospective study that was done with my group, published not long ago in The Oncologist, that try to see what's happened when people are using cannabis and taking immunotherapy. We are all familiar with cannabis use as actually in autoimmune disease. We are giving it in IBD, we are giving it in multiple sclerosis. We use it very successfully in GVHD. They are all suppression. Its indication is to suppress the immune system. So when we are treating in oncology, trying to induce the immune system and trying to make it to work faster and harder, and we are giving cannabis, what's happened? So it's a retrospective data, and it should be taken with caution, but you can see that less patients respond when they use cannabis and start immunotherapy. It actually was half of the patients if we are taking it by percentage. And even if we took out the patients that died in 2 months, because we know that those patients are not responding to immunotherapy when their general condition is not good, you can see that in lung cancer, just half of the patients respond, and in melanoma and renal cancer, it even was lower. So it's a retrospective data, as I said, and I'm not saying that patients don't need to take cannabis when they are using immunotherapy, but I think they should know about those results and take it in account. We are now analyzing, together with Professor Dedi Meiri in the Technion, we are now analyzing a prospective data, the same data, of people who used immunotherapy, and part of them use cannabis as well. It's around 100 patients. A third of them use cannabis when they start immunotherapy. We took blood sampling during the treatment, and we analyzed, of course, the clinical data. But together with analyzing the clinical data, we also analyzing with mass spectrometry the phytocannabinoidin and the endocannabinoidin levels, trying to make it all together and understand what's happened to the cannabinoids according to the clinical data that we have. And together with this, we also analyzed the cytokines level, the pro and anti-inflammatory cytokines, trying to make all the data together and bring some clearness to this point of what's happened when people are going into immunotherapy to their illness and taking cannabis in the same time, because immunotherapy is now indicated for almost every cancer illness according to the lines of the possibility of treatments. With the same laboratory, we are now focusing on chemotherapy-induced neuropathic pain. We know that cannabis works better in neuropathic pains than in other kind of pains. We have many chemotherapies, and mainly the taxanes and the oxaliplatine that used in the adjuvant setting of cancer. So it's a healthy person after doing surgery for his cancer, and then he or she, it's in breast and colon cancer, are given chemotherapy for half a year to prevent recurrence of their illness, but they have mainly neuropathic pain that is coming during the treatment and can stay for a very long time. So it's very interesting to see if we can give cannabis to those patients and maybe prevent the long-term neurotoxicity and the acute-term neurotoxicity. And this study will also be done with analyzing the phyto and the endocannabinoidin to understand the system much better than it's now. This is a study that was done with my team and still not published. It's under review. That we use capsules, doses control capsules of cannabis, slow release, to treat anorexia and cachexia syndrome of cancer patients. It was a phase 1 study, and we start with too much cannabis, I can say. We used 10 milligrams of slow release capsules once or twice a day and reach toxicity that was not acceptable for those patients, and we lowered by half the dose. And as far as I can think, we can lower it more. The primary objective was to gain of 10% of more of your weight. I'm not going into the details of those studies, but we can see that around 80% of the patients reach this primary endpoint. And it's very good to continue from this point to a larger study. And even patients that did not reach the primary endpoint reported improving in appetite and other outcomes related to it. This is a new direction, I think, in cannabis treatment, trying to be more specific when you are doing a research and that connected to side effects. So this patient is 45 years old. We published it as a case report a few years ago. He had basal cell carcinoma. It's a skin cancer that grows deeply very into the tissue, not sending metastasis. And I don't know why, but he's a normal person, but he hid his tumor for many years, and it became very large. And there is a specific target therapies, H-dog products that blocked this oncogenic system that's specific to basal cell carcinoma. The first drug was vismodegib, and that was his treatment. And there is another drug called sinodegib. Now you can see this person after 4 months, how it looks, and after 8 months, it's completely disappeared. But the problem with those drugs that they have side effects of muscle cramps. Now these side effects cause patients to stop the treatment. And if they are stopping the treatment, the lesion came back again. It's not really destroyed by 100%. And that was happened with this person because of his muscle cramps, he have a very high enzymes called the CPK. It's enzymes that's going up when you have muscle cramps. And he stopped the treatment, and it starts to come again. And you can see it now, it's also caused hair loss. And you can see it now, 4 years ago, after 4 years of treatment with the same drugs, we published it again as a letter, because we gave him cannabis in higher doses, and his CPK came back to normal. The muscle cramps will still exist, but much in a lesser amount, and he can continue his treatment against cancer. And that brings us to a new study that we hopefully will start in the coming months with the drug, the competitive drug Sinodijib, is a new formula, to see if people who are using the drugs can tolerate the treatment much more when they start the drug together with cannabis. And hopefully it will give us a new option to those patients to continue treatment for a long time. So to summarize, we are using cannabis really for palliative indication. We have more data about cancer-associated pain and chemotherapy, nausea and vomiting. We have some data on other symptoms like depression, insomnia, anorexia, cachexia. Is it, what we really want to know, is it a treatment to cancer? I think it's too early. And the system is too complicated really to say the patient take it for cancer in higher doses. It can work to both sides, and we need to do clinical research, but also with laboratory research, not just to see if it works or not, but how it works and to whom. I think it's very important. So thank you very much.
Professor Gil Bar Sela, thank you so much, Professor. Very much appreciate it.